Brilliant. Well, welcome everybody. Thanks very much for joining. Thanks to all our speakers for joining in a beautiful day in Edinburgh. Welcome to everybody for joining from Scotland, from around the UK and around the world to our Scottish Medical Imaging Showcase. We're often accused in Scotland of doing great work but not telling people about it. Well, we want to do something to change that. And because I know that everyone speaking today will testify to the great nature and the further opportunity that comes from using medical imaging data to improve research, and that improves people's lives. Medical imaging service uses research available from a de-identified copy of all medical images routinely collected in Scotland between 2010 and 2018. And the associated de-identified radiology reports for these images. And of course, we've got the ability to link that to other aspects of people's health and care to predict, prevent, and make decisions that improve lives and well-being. I work at Research Data Scotland, who is set up by Scottish Government, Public Health Scotland, and universities with the mission and the remit around making it simpler and quicker to use public sector data for improving lives and research. And medical imaging data is an essential part of that puzzle and something where Scotland is well placed to lead on capabilities. So Research Data Scotland's agreed funding from UK Government Office of Life Sciences will also be helping to start to update those imaging data post 2018. And that will give us very much an unparalleled data resource across the UK, strategically important. So today, we've got some fantastic speakers, but at the end of that, we'll have some time to do some Q&A. So feel free to either use the chat function to put your hand up at the time, or raise questions when the time comes for that. And I'm keen that we've got plenty of time, so I'm sure all of our speakers will be fantastic at sticking to the times that they've got. We'll be hearing later from some of the leading researchers who make this ambition real, using imaging data in their work. And we'll be hearing from the team of Public Health Scotland, who curate the data and make it available for use in research. And we'll also hear from Cathie Sudlow, Director of the Usher Institute at the University of Edinburgh, and the author of the Sudlow Review into how we make the most of data-driven research. But first of all, can I introduce Richard Lochhead, Minister for Business and Employment with the Scottish Government. He has championed both the use of AI in public services and research, and of our life sciences industry and health technology sector here in Scotland. So there could be a more fitting person to introduce us this morning. So over to you, Minister.
Thank you very much, and thank you very much to Research Data Scotland for inviting me along. I'm only here for a short while because I've got to go around the corner and speak to the Scottish Tourism Alliance annual conference. So it's a lovely day here in Edinburgh for tourists, but this is one of the industry, obviously. But this is really important, and this is a cause that's been close to my heart for a long time. And I think right back at the beginning, I was there for the launch in my previous role as Higher Education Science Minister of Research Data Scotland. And as I said before, I paid close attention to all the opportunities this agenda brings for Scotland, and it's good to be at a Scottish medical imaging event. So bring our clinicians, our researchers, our data experts, our innovators all together to bring benefits to patients, and our health and social care services is so important. And of course, research is at the heart of that, and Scotland's research excellence as well. I recently just launched Scotland's refreshed life sciences strategy, which was very much led by the sector, but supported by the Scottish Government. And I did that through the University of Dundee. And clearly we now have a really ambitious policy in place for Scotland's life sciences sector to get to £25 billion by 2035, after they blasted through their 2025 targets back in 2021, which shows the growth of the life sciences sector in Scotland. So this is very much, of course, at the heart of our life sciences strategy in Scotland. So obviously today I'm very pleased, therefore, to be at this event where I'm announcing, and we're all announcing together, that we're providing £200,000 to Research Data Scotland to support Scottish small and medium enterprises, or SME community, to develop innovative products using data research through the Research Access Service. So that's a competition for those that want to get involved, that will aim to reward all the successful SMEs with up to £60,000 worth of RDS time and expertise as well, obviously to identify and help analyse data to bring forward new and innovative developments of the sector. So I'm very much here with my Minister for Innovation hat on today, as well as being the Minister who leads with our engagement with the life sciences sector. So, this is fantastic. And clearly, given where Scotland is with our life sciences sector, where the world is with technology and AI and everything, this is exactly the sort of projects we should be supporting. So I'm delighted that we're announcing that today. And of course, it's also about ensuring Scotland is in the lead, and not just in terms of what we're doing, but internationally as well, and recognise that, because we do have world-class life sciences expertise and research expertise in Scotland. So it's about making sure we don't fall behind, but we are leading as well, and we keep up our reputation for that excellence as well. So medical imaging, and I speak to many companies in the life sciences sector involved in medical imaging, and I'm sure many of them are online, hopefully participating in this event today as well. It is one of those areas where we have a strong academic and clinical base, and also is a sector that's full of opportunity as well to improve outcomes for people, to accelerate diagnosis, and of course just improve our healthcare services overall as well. So clearly imaging is so essential to modern healthcare. Radiology and pathology underpin almost every patient pathway, as I said before, from early diagnosis to treatments and all the planning around that as well. Now, our data strategy for health and social care was published back in early 2023 as well. Again, since then, we've seen some important successes that have been taken forward, delivering a lot of research assets across the country. So RDS, alongside the data safe havens, the Public Health Scotland's work, and working with all other stakeholders as well, it really is helping to create the foundations which can secure access to data for research and make sure that's further developed and utilised as well. So we have to do all we can to make sure there's better availability of data that can be accessed through the Access Service. And I know there's 7 new projects that are going to be delivered or are being delivered over the past year and going forward as well. And there's a lot more in the pipeline that are going to be brought forward as well. And of course, the Safe Haven Charter was refreshed in 2025 to enhance data access, security and governance. And that was made possible through the collaboration of the Scottish Safe Haven Network that many of you will be involved with, bringing together RDS and also our national and regional data safe havens as well. I'm pleased to read that we've got progress that has been delivered in that, and that the time for submissions of research going to the panel decisions for access to data is now down from 45 to 20 days. So I really just want to finish by saying that as Minister for Innovation, as the Minister, as I said before, that liaises with the life sciences sector in Scotland, got responsibility for that. I want Scotland to be a test bed for innovation. I want Scotland not just to have the best data and the best research and the best clinicians, but I need all that working together to make sure we get the best outcomes as well, and we utilise that, and we support our business community at the same time, and all the companies in the life sciences sectors to grow, continue exporting, and lead the world in their relevant areas. So this is a big picture, as well as medical imaging, which is an important part of that much bigger picture at the same time. So I just want to wish everyone the best of luck, and all our SMEs, to encourage them to take advantage of that as well. So I think now it's time for me to thank you for having me along. I'll be leaving, I'll stay for a wee while, but forgive me if I have to disappear. But I'm going to hand over now to Professor Cathie Sudlow, Director of the UK Research and Innovation Adolescent Health Study, and obviously Director of the Usher Institute at the University of Edinburgh.
Thank you very much. It's really great to be here discussing this incredibly important treasure of imaging data that we have in Scotland. So in a previous role, when I was working as Chief Scientist for Health Data Research UK, I had the privilege of producing a review for UK government, which was commissioned by Chris Whitty, the Chief Medical Advisor to UK Government and Chief Medical Officer for England. and Ian Diamond, who was then the national statistician for UK government and NHS England, to conduct a review of the UK-wide data, health relevant data, and to make some recommendations on how those data could be used better for patients and public benefit. So we have, across the UK, with its population of 67 million or so people, many, many rich sources of data relevant to our health that come from the healthcare system, mainly the NHS, of course, and beyond. So we have data sets that are brought together and collated nationally. Those are mainly highly structured data sets, codes, dates, that kind of thing. They could largely be represented in spreadsheets, and they are returned at national level in each of the countries of the UK, and increasingly are available, linked together, and accessible in secure data environments remotely by approved researchers. And in Scotland, of course, that enterprise is overseen by Research Data Scotland. There are also more detailed granular data, things like images that are ascertained through radiology studies and images of the retina and so on. Free text in electronic medical records. These are some good examples of more granular, complex data that are generally held and accessed locally and regionally. In Scotland, however, at entire national level, we have this Scottish Medical Imaging Collection. I am not aware of any collection of images that is linkable to other health data at entire country level anywhere else in the world. So this really is an amazing resource, and we should be aware of that. And it's one of the areas where Scotland really is world leading, but I think there's capacity to do a great deal more with that collection of imaging data. So that's the second type of data. The third type of data is health relevant data that comes from outside of the NHS, data, of course, from social care, but actually data from other sectors, education, income, justice data. These are all extremely relevant to health and for understanding the wider determinants of health and determining our health policy. And then we have data that we kind of collect, even if we don't know about it, every day through wearables, apps on our mobile phones, and environmental monitoring of the weather, air pollution, and so on. And then we have data that, as researchers, we obtain from participants who've consented to take part in research studies such as trials or large population-based studies such as the Adolescent Health Study or UK Biobank or Generation Scotland, to talk of a local example. So the issue is that each of those different sources of data is in and of itself valuable, but when data sets are linked together across these different sources, that is when the magic really starts to happen and the insights really start to come out. So our challenge in the UK, and Scotland is no exception here, is that we have complex and inefficient systems by and large for the access, linkage and analysis of these data. And the solutions don't lie in any one area. So some of the solutions are technical, some of them are socio-cultural, some of them are related to investment, but we need kind of an understanding across all of those. So we generally don't use our data as well as we could for patient and public benefit. But where we do, where whole population studies, for example, have occurred, it's possible to monitor vaccine uptake, it's possible to monitor medicines usage and look at adherence to medicines. It's possible to monitor the long-term consequences and determinants of a wide range of diseases. And many of these examples started to come to light during COVID when our system became more permissive without, I have to say, any disasters. So why we haven't continued with that somewhat more permissive system, I think, is a mystery to several of us in this room and probably joining the meeting remotely. Studies using the more granular complex data, of which the Scottish Medical Imaging resource is a great example, have huge potential. But they are challenging because these more complex data types often need more complex analytic approaches. They are absolutely fantastic substrates for artificial intelligence type of approaches, but that means that we need to ensure that our data platforms can accommodate these types of advanced analytic techniques to make sure we take advantage of them. So we'll hear more about the Scottish Medical Imaging resource in a moment, but 57 million imaging studies going back over about an 8-year period with no less than 2.5 billion DICOM images is a very substantial resource of data and huge potential. We'll hear more of that later. Then these kind of cross-sectoral studies where we can look at the wider determinants of disease, which involve the type of work that Roger is leading in Scotland and others in the other nations across the UK, where we can, for example, look at the impact of early education on later life health outcomes, or early life health and its impact on educational performance, or the interaction between health and wealth, for example, by using income data. These are incredibly important, I think, for informing government policy. Clinical trials and blood-based cohorts are massively enhanced by the capability to link to these whole population data assets that aren't collected primarily for research, but have huge research potential. So those are a few examples of the types of things that are possible, and with respect to imaging, we'll hear more of those specific examples from a Scottish context later. But I would say one point worth making is that the examples we're going to hear are led by academics. It's a great place to start, but there is huge potential for our colleagues from industry to interact with and create massive potential from these data. I think these data assets are hugely investable as well. So large and smaller companies can help us to build these assets and make them better by investing in improving them, perhaps through pre-competitive types of investments, which I think is a great way of driving improvements in these national initiatives. So my review that I submitted to government back at the end of 2024, somewhat surprisingly, has had impact that I don't think I expected. I thought, like most PhDs, it would sit on a shelf and gather dust. I suggested that we should define health data across the UK and in each nation as part of our critical national infrastructure, all of those sources of health data, that we needed a national health data service, and indeed now a health data research service has been established with investment from a combination of Wellcome and UK government of £600 million. If we get our act together really well in Scotland and showcase our potential, we should be able to attract at least 10% of that investment. So that would be my target for Roger and others sitting around the table, to really push for that kind of investment to capitalise on what's already happening up here. All of this, of course, needs ongoing meaningful engagement with and involvement of patients, public and health professionals, particularly health professionals, actually, because of the importance of sources of data that are controlled by health professionals, especially primary care data. Some of the legislation that has been required in England to take that forward has now been put into place. And so when it comes to primary care data, it's really important that we catch up and really make the most of the infrastructure that we have here in Scotland. So I would say, in summary, that some of the examples we're going to hear about this morning and some of the other broader examples are somewhat exceptions. They are not yet part of our business as usual, and I think our task is to make what we see as currently wonderful exceptions into our business as usual, and that we need to adopt an attitude where we consider the risk of not using these data for patient and public benefit, because by not doing so, we are letting patients, public and all of their families down. And sometimes I think we're inclined to think about the risks and overemphasize the risks of doing this. So I think we need to turn the tables to really drive this forward. Thank you.
Thank you very much.
Oh, yes, and I should hand over to my dear colleague, sitting on my right-hand side here, Carole Morris, who's the leader and director of eDRIS. We do all the work in the background to make this stuff happen.
Thanks, Cathie. No, I now feel very pressured to follow both of you. So thank you very much. I'm Carole Morris, I'm Head of Data and Modelling Services in Public Health Scotland. And what I want to do today is just give you a bit of a history of the medical imaging for research and the work that's happened over the last few years. And then a little bit about what we've got now and a little bit about where we're kind of some of the ideas we're heading towards in the future. So, unique, I think Scotland has been mooted by both previous speakers. We were in a unique position. We had a national picture archiving and communications system that was nationally rolled out. The completion of that was done in 2010. So that gave us an idea of creating a research-ready imaging data. So we had to take this opportunity while it was available to us. So with support from Far Institute Scotland, which was a UK-wide initiative which Scotland was part of, about 10 years or so ago. And with support from the NHS Scotland Caldecott Forum, we were able to get governance and permissions in place to transfer copies of images from 2010 to 2018 during a version upgrade of the National PAC system. And following that, we were then after a lot of hard work and planning, we developed an architecture in partnership with the University of Edinburgh and the University of Dundee, and we were able to extract images from the proprietary format and start to de-identify modalities, so MRIs, CTs, radiographs, etc. So that kind of gives you a little bit of the history, what's been happening now. On the next slide. Is that I cannot emphasize this enough. It really does take a village to grow things. So in starting, Emily Jefferson and the University of Dundee and our colleagues in the Health Information Centre up there put in for a grant, Pictures grant, for 5 years for 4.5 million. And so this funded the identification of different image modalities, the creation of a cohort extraction tool, and we were able to develop the platform hardware and software, and then take forward a couple of exemplar projects with industry and academia. And around that, we were also able to work with other colleagues on public engagement in respect of using medical imaging data within the research sphere. And the de-identification, there's so many different modalities. We've been working through those in order of priority of what people are more interested in to undertake research on. And all of this work essentially has laid the foundations for work that's been carried on by HIP around digital dermatology and work that's been carried on by the University of Edinburgh colleagues in bringing in and curating retinal images from high street optometrists. And that just gives you a little bit of an insight into where all this is. But I really do have to say it does take a village to make all of this happen. There are so many knowledge, skills and expertise that have been brought together from the NHS, from academia, that has really made all of this happen. So alongside the Pictures grant, we also had some project funding and some of the UK-wide trusted research community work. So that has given us opportunities to use natural language processing to de-identify and extract information from the radiologist report. So that's the ones that accompany the images, and that was driven through the Scottish Government's programme for government. We've been working with clinicians to continue to curate the data. So, for example, triangulating body parts. I hadn't realised there was kind of lots of different ways that you could just essentially, and I'm simplifying because I'm not an expert in this area, but talking about a knee, for example. We've been working with Health Data Research UK around developing the metadata and incorporating that into the Gateway, which is a fantastic source of the data resources across the UK, and then looking and continuing to look at ways we can develop the IT platform so that we can support AI and large-scale programs of data. And alongside that, obviously, we have to always ensure that we're keeping data safe and secure. So we've been working with the trusted research environments across the UK to look at how we can ingress and egress models safely and securely so that there's nothing disclosive that's ever released from a secure environment. So in Scotland, we have the Scottish National Safe Haven Environment. University of Edinburgh, our EPCC colleagues operate that on behalf of Public Health Scotland. It is a Digital Economy Act accredited environment. It's an ISO 27001 accredited environment and Cyber Essentials, so that we can address as many needs as possible. We have a Linux operating system and we provision Python and R software. We have GPUs and we are working on the shared high performance computing, so GPU clusters, for example. And at the moment, we are working around how do we better support the research community. So there's lots of different softwares, whether it's been developed by academia or whether it is software that is being developed elsewhere, that people are wanting to use for undertaking machine learning, AI, or other analytics. So we're looking at ways that we can provide containers where software can be brought in safely and securely and allow the researchers. And I mean, these are experts. As we're running TRE environments and we're trying to keep up with the knowledge and expertise and the rate of evolution of all the kind of analytical tools that are available. And also because data is getting bigger, complex, different types of data, we're working with the UK TRE community and looking around how do we do federated analysis so that data can remain where it is, eyes-off analysis can happen, and it can happen across different sites. So that just gives you a bit of an insight into our systems at the moment. So some future work that we're working on. What does it hold for us? So we've been working with Whiteley, who's going to speak after me, and others around things like researcher-generated objects. So things that are being developed through research projects but could be reused by other research groups. So that kind of creates efficiencies in the systems, both in terms of time and resource, but also in terms of computer use as well. We're having discussions with our colleagues in National Services Scotland around, as they migrate to the new PACS provider, is getting more up-to-date imaging data from 2018 onwards. And we've been working with our information governance and our senior risk officers and also public engagement around growing our knowledge, our processes, and all of our understanding around AI and that world related to that. And obviously we're doing work with Research Data Scotland and other colleagues around industry engagement as well. Alongside that, and I think the key thing is that we are having to look at what are our funding sources. So we've got project-based income, we've got research grants. We need these to invest in the infrastructure so that we can continue to do all these developments alongside supporting research projects. And that helps us to scale up and it helps us to more effectively support programs and projects. So I'll finish on that note. And I think as I hand over to all the experts who have so much more knowledge in this space, I'm going to hand over to Professor Will Whiteley to talk about some of his work.
Great, well, thanks a lot for the introduction. It's just fantastic to hear where we're going in Scotland with this resource. So I'm going to talk about a project using brain imaging data funded by these largely public funders, although over the period we have had one funder from industry. So the Scottish Medical Imaging Initiative should be an absolutely fantastic resource for study into diseases of the brain. NHS Scotland provides care to all Scots pretty much, and with about 5.4 million people, it's large enough for population insights, but because people work together, really it should be a resource that's small enough for experimentation. Scottish Medical Imaging, which contains images from every NHS scan between 2010 2018, is an enormous resource, about 2 petabytes of data, and it's co-located with EPCC, and I think we'll hear later on from Yano about that, and the University of Edinburgh GPU cluster, allowing relatively modest cost academic machine learning. And there are many cases of dementia and other neurodegenerative illnesses in people who've been cared for by the NHS. Dementia alone, there are more than 40,000 people. So it gives us sufficient power to start to think about this resource for a number of interesting projects. And the structure looks something like this. So we have within the Scottish National Safe Haven, which is run by Edinburgh Parallel Computing Centre, anonymised linked healthcare data, the ability for bespoke researcher-developed machine learning tools, and secure access for approved researchers. And that brings in pixel-level data from images, text reports, and all their metadata. The NHS Scotland linked data, largely at the moment from hospital deaths and community prescribing, although we do hope to hear from primary care data soon. And then there are specific highly phenotyped data for particular neurological phenotypes like motor neuron disease, multiple sclerosis, and stroke, where we can look in more detail about people's disease course. And then the team are developing ways in which those models can be exported and shared to use in other environments and beyond. So I'm going to talk about a quick use case now my own particular area of interest, which is thinking about cerebrovascular disease. So when we've done this project, we've done it in 2 stages. The first stage is the relatively easy stage to try and develop phenotypes from the text in the reports that each radiologist gives us. So over the time that we've developed this was before the days of ChatGPT, we developed a bespoke rules-based natural language processing system that allowed us to get markers of this condition, covert cerebrovascular disease, from brain imaging report. And that is important because if you have this radiological finding, which is not usually accessible to us, you have about 2 to 3 times the risk of stroke and about 1.5 times the risk of dementia over your life. So we developed reports to try and find these phenotypes, and on your right, you can see how we did that with our rules-based natural language processing. And we ran that across the entirety of the brain imaging data in Public Health Scotland. That's around 1 million scans from around, in this case, 650,000 people. And that gives us enormous numbers of our condition of interest, which is cerebral small vessel disease, another name for covert cerebrovascular disease, but also very large numbers of people with rarer conditions, like the benign brain tumor meningioma, which is largely understudied. So we're able to bring out these phenotypes quite quickly. And we can then look at these at scale. So we can, these are now one of the researcher-generated outputs for use by other people. This allows observational epidemiology and allows us to refine disease phenotypes such as stroke and dementia and putting those into subclasses, improving our thoughts about prediction. We can deploy that now in the safe haven. We've done that in the regional safe haven in Edinburgh. And that means that we can now start to think how to approach people for clinical trials based on their phenotypes that we've developed from text. And we can imagine soon how we could do that from phenotypes based on images. And we're just running through the patients and public participant involvement and the ethics of that at the moment, but we hope to start approaching people later in the spring. So that's what we've done with the reports, a relatively simple thing. But then we started to work on images. So with these funders at the bottom, we then tried to develop free AI approaches to predicting dementia over time using MR brains. So we compared the performance of support vector machines, deep learning, and then AI methods of measuring conventional phenotypes put into linear algorithms, all of which, for our purposes, gave similar performance. But remember that whilst MRI scan is much more detailed than CT, CT is the most widely used and commonest of the imaging of brain in over Scotland, and so the project is in progress to look at that. The current project that we're working on at the moment with Rob, Jackie, and others is how do we build models that work in 2 secure data environments. And so we have 2 projects on that. The first project, which is here, is one that's funded by both the UK Dementia Research Institute and the German equivalent, DZNE, to try and build dementia prediction models across 2 secure data environments, one in Finland, which has got a very similar governance structure to Scotland, and one in Scotland. And thanks to the hard work of EPCC colleagues, we've worked out a way of implanting the software in both of those sites, and we now have governance approval for this project, where we can have a deep learning model that works across both environments for prediction on a common data model. And of course, in the fullness of time, if this works as our pilot, we can then expand to other European secure data environments, and we have collaborators in both France and Germany who are interested. We're working on a similar but slightly different federated device with colleagues from the Gates-funded Alzheimer's Disease Data Initiative to allow people to access and analyze data without seeing tabular data, but able to draw out research tables with colleagues currently in Stanford. So what we've developed is a brain health data pilot. So for brain health, we're sure we can do for the rest of the health, and we've discussed that with Michelle Williams and others. So we have an evergreen data set with streamlined access. So we for particular purposes of prediction, We've made applications easier. And thank you very much to Carole for your work on that. It's accessible for international users. There's a GPU cluster. And the most important thing is to make sure that patients and citizens know what's happening to their data. And we have done and continue to engage with them. And that gives us two buckets of projects. We can enrich data for epidemiological and healthcare improvement analyses using those natural language processing algorithms, the pixel-based phenotypes, and linkage to cohorts, which allows researchers who perhaps don't have as much computing experience to use those data. And then to reduce time to AI, we've developed a method of standardizing imaging selection. We've got a pipeline for image preparation. And then thinking about how to work with colleagues in other countries, we're developing both these federated devices. So there are many opportunities, and I think whilst these five opportunities work for brain imaging, they work across the piece. So we've got natural language processing of reports, which are important for real-world evidence studies, people looking at hard to define dementias, strokes, or tumor types, which otherwise are difficult to get from electronic health records. We can develop foundation models with different imaging types. We're working with UCL on that. We can improve phenotyping for the linked large-scale cohorts. In Scotland, we've got Generation Scotland, and we're working on improving phenotyping of stroke and dementia. We could approach people for clinical trials at scale using otherwise hidden illnesses. And for people developing radiological imaging algorithms, you could understand the accuracy of different techniques at really large scale and in practice using the data we provide. So that's some of the stuff we're doing. So I think I'm handing over now to Professor Michelle Williams, who's a Associate Director of the British Heart Foundation and Professor at University of Edinburgh. Michelle.
Thanks very much indeed, Will. So it's lovely to be here today. My name is Michelle Williams. I'm Professor of Cardiovascular Imaging at the University of Edinburgh. I'm Associate Director of the British Heart Foundation Data Science Centre, and I'm Chair of the European Imaging Biomarker Alliance. I'm here today to talk about the work that we've been doing with the Scottish Medical Imaging Dataset and the British Heart Foundation Data Science Centre, University of Edinburgh and King's College London on cardiovascular disease. So heart and blood vessel disease remains the biggest killer worldwide. Globally, 1 in 3 deaths are due to cardiovascular disease. In Scotland, more than 800,000 people are living with cardiovascular disease, and it accounts for 28% of all deaths in Scotland. So that's nearly 50 people dying every day. And when it comes to heart and blood vessel disease, we have lots of ways of looking at this now. We live in an incredible time where we can really see inside the body. Some of these tests we do very often. Chest x-rays and echoes and ECGs are done routinely. Other tests are done less often. MRI scans, PET scans, CT scans are done for patients where we need more detailed information. And Scotland has always been ahead of the curve in terms of access to some of these technologies. Scotland has one of a handful in the UK total body PET scanners, photon counting CT scanners, and high Tesla MRI scanners. Most imaging tests could have extra information about cardiovascular risk and cardiovascular disease, even if they're not done specifically to look for the heart and blood vessels. Routine imaging contains information about the heart in anything that looks at it. And these are some examples of hearts and blood vessels and the sort of things that we can see on these scans. And most of this information is never used. So the Scottish Medical Imaging Dataset, as we've heard, is an absolutely incredible resource. It's the only national imaging dataset in the world that can be linked to other datasets, and that's incredibly important. But we want to find out some extra things about this dataset in order to make it really research ready so that researchers can come and rapidly be able to do their research, use the imaging datasets, and get the results of their research. So there's 2 important questions that our project is aiming to address. One is what cardiovascular imaging is available within the SMI dataset? And the second is what imaging have patients with cardiovascular disease that are in this dataset? And this will help researchers plan their research in 2 different ways. So the SHIELD CVD project aims to improve the accessibility and usability of the SMI dataset for cardiovascular research, to help with the people who are approaching this from applying to access and use the dataset with our top tips and experience of using it, to quantify how much cardiovascular imaging there is in this dataset and how that's changing over time, to develop reusable code for data curation and analysis, and conduct an exemplar project around coronary artery disease, which is one of the most common cardiovascular diseases that I get asked about. And underlying all of that is generating a community of researchers who use this imaging data set so that we can share learning and share resources and develop it further. So I'm delighted to let you know that the SHIELD CVD project has been moving very rapidly. We got access to the data set just before Christmas, and it's a very large amount of data, as you can imagine, and that's been slowly coming into the National Safe Haven shared area for us. And just in the past few weeks, we started the data cleaning and curation of this data set. We've been developing the research community. We've held a series of webinars, so please do check out the BHF Data Science Centre YouTube channel, as all the recordings of them are there. We've been doing the data cleaning and curation. This is going to take us a little while, but we've started it, and we have some initial results, excitingly, just released last week that we can share with you today. And we're now working on creating these shared cohorts and reusable data code that will be able to be used as research-generated outputs by other researchers so that we can really kickstart cardiovascular imaging research. We've got 3 different levels that we're working on our curation of this data set. The first is imaging-based. So based on the DICOM metadata, that's the information about the images themselves, we're working on creating cohorts defined by things like the modality, the body part, the study type, what sort of reconstructions or sequences are in there. The second is disease-based, so based on the linked data sets using the variety of imaging codes, or based on the text reports using the NLP or other approaches to curate things based on what diseases or phenotypes are present in the images. The third is based on risk factors. So this is based on the linked data sets. So maybe based on the demographic characteristics, the traditional cardiovascular risk factors, but we also want to highlight the forgotten cardiovascular risk factors, things that people often don't think about, like pregnancy or cancer and other medication use. And there's obviously also overlaps between these 3 categories. So imaging and disease-based cohorts might be particularly useful for researchers or SMEs who are wanting particular types of imaging to develop or test their machine learning tools. So, hot off the press. This I just saw on Friday, so that's why my slides were late in coming in for this session. This is the data that we're looking at the moment. So here you can see in number of studies per month how between 2010 and 2018 what imaging is in here. You can see very nicely the change between traditional computed radiography and digital radiography in Scotland, with the increasing use of the digital X-ray techniques there, as well as the increasing use of CT scanning, MRI scanning, and positron emission tomography. We've been starting to delve into the demographic characteristics because for cardiovascular disease research, this is very important. So we've been looking at the distribution of age and the distribution of sex within these data sets. Some imaging types are more commonly used in older or younger people. For example, CT scanning is more used in older people and MRI scanning more used in younger people. And really importantly for cardiovascular research, across the imaging modalities, we have an almost equal sex representation. Many data sets around the world have an underrepresentation of females, and this is very important that this data set really does have a very balanced distribution across the different imaging modalities. We started creating our cohorts. So these will ultimately be the research generated outputs that other people can apply to through Public Health Scotland to use. Ischemic heart disease is one of the ones that we're asked for most often. So this is where we've been starting. So we have here an example of what imaging tests have been used in the patients 1 month before to 1 month after a diagnosis of ischemic heart disease appearing. And you can see we've got lots of all of different imaging tests to explore here and very large numbers of data. And we can also see how that imaging test use has been changing over time. Importantly, some of the imaging tests are rapidly increasing in their use in Scotland, and this is a fantastic resource for the research. But also an important aspect of all of this is to understand how imaging is being used in Scotland. And so we're starting to work with health economic researchers and policy developers around how guidelines change imaging use and how we can model and think about this in the future. So in conclusion, the Scottish Medical Imaging Dataset is a really unique resource which has fantastic promise for all sorts of different types of research. And my focus is very much on the cardiovascular aspects, but blood vessels go anywhere in the body. So actually it does incorporate all types of disease. The SHIELD CVD project is working with the cardiovascular imaging community to create this data set to really make it research ready for them so that people can rapidly go in there knowing in advance what they're going to be dealing with and using the reproducible code that they can really kickstart their research and hopefully provide important benefits for patients and the public. And there is enormous potential here to not just understand cardiovascular disease, but also develop new methods to diagnose it and new methods to treat it. So I'd be happy to answer any questions. Please do check out the SHIELD CVD webpage on the BHF Data Science Centre or drop us an email if you would like to know anything more. And I'm now delighted to hand over to Grant Mair from the University of Edinburgh, neuroradiologist.
Thank you, Michelle. Thank you to everyone for inviting me today. So I'm just going to give an example of a much smaller scale project that's nevertheless taken advantage of the national scale of the data. And it's something that we're calling the CT clock that we've validated using these data. So I'm just going to give a little bit of background to what is stroke and how stroke is burdened. Scotland is burdened by stroke and what the problem is that we've tried to solve with our method. So what is a stroke? Well, it's a sudden disruption of blood supply to the brain. Most strokes are ischemic. That means there's a blocked artery preventing oxygenated and blood with glucose getting to where it needs to go. And it's immediately disabling. Patients often have symptoms with their arms, legs, their face, their speech. The FAST campaign you may have seen is the government's effort to try and encourage the public to recognise this as a medical emergency. Scotland has over 10,000 strokes per year. And from that, roughly speaking, about a third of patients die, a third are left disabled, and a third recover. And in addition to those effects on those individuals, there's a national burden of this in terms of health costs, days not working, and care costs that is rising continuously with our ageing population. So what are emergency treatment options for stroke or ischemic stroke? Well, the first thing that the traditional treatment for 25 years or so has been thrombolysis, which is to inject a medicine to break down the blood clot that's causing the problem. However, you have to give that medicine within 4.5 hours. More recently, some people will be aware that a new treatment has come online, which is called thrombectomy, where using a tiny catheter, we can pull the clot from the artery, which is highly effective and has excellent outcome results. But you have to be in that particular centre to have that. But in addition, it tends to also be limited by time. So we're continuously limited by time in this scenario. The problem that I've been trying to deal with is that about a quarter of patients with ischemic stroke, we don't know the time, and for these kinds of reasons. Now, if we don't know the time, other research has gone on in the background that says, well, that's fine. So every patient in Scotland and mostly around the world gets a CT scan when they come into hospital when they have a stroke. But if we can do these additional tests, then that's great. We can still work out from these 25% which ones we should treat. However, if we look at a map of Scotland and we look at the centres that can offer that advanced imaging in an emergent scenario, you have to live in one of the big cities really to be offered this. So there's 25% of people living in other parts of Scotland, and this I'm sure is replicated across the world in less well-resourced places or places outside major centres, you're not going to be able to be offered these advanced imaging tests, and therefore you're not being offered treatment that could help. So what I've done is using this recognition. This is what we know about stroke. This is the same patient at different time points on their journey after the stroke. And you can see along the bottom left of the image of the brain how the stroke becomes more and more obvious with time. There's essentially an increase in water or edema being laid down in that injured brain tissue. So what I did is took a data set from a large clinical trial and plotted how that change in water density or attenuation works against time, and then added a line of best fit. So when you take another patient and you measure the attenuation of their brain, you can estimate the time, and then hopefully you can treat them. And we found that in that controlled environment, for predicting whether a patient was under 4.5 hours or eligible for thrombolysis, it was highly sensitive and moderately specific. What that means is that if the patient is under 4.5 hours, we're very likely, 97% likely to identify that. However, if they're actually later than 4.5 hours, we get that less well. And I should say the reason for that is not necessarily that the technique is problematic, it's that some patients don't follow the trend, because if they've got a blocked artery, some patients have other arteries feeding the area, prolonging that tissue, which is great, which is exactly the patients we're trying to find. But it means that our system pushes them into under 4.5 hours category when in fact they're at 7 hours or something. So that lower specificity isn't really a problem. It just means that we're identifying the correct people. I suspect we need to change the metric and how we measure it, but it's the one I've used today. So if we think about, well, why am I doing this? If we think about, come back to the map from Scotland, where you have to have advanced imaging if you're one of those 25%. This is the kind of scenario that might be if we use something like the CT plot, because each of these hospitals has a CT scanner and could theoretically use our technique for those patients. So that's what we're trying to get at. So what is the method? Just in simple terms, we've shown you what an ischemic stroke looks like. It's a very advanced one for the purposes of demonstration. But essentially, we ask clinicians manually to measure the attenuation. And it's quite deliberately a manual technique and not a fancy computational technique, AI technique, because we want it to be accessible wherever you are. You don't need to have any fancy software to do this. You just need the CT scanner, the viewer that you've already got, and you make these measurements. So what we did is we used Scottish medical imaging data set to validate our technique. As I've said, I used a randomized controlled trial data set initially to develop the technique. The problem with that is that clinical trials are highly selective who they let in. They exclude lots of people for lots of reasons. It's likely that they exclude some of the sicker patients because they don't necessarily fit with their trial and wouldn't necessarily benefit from the trial. But we want to see what happens across the piece, if you like. And also in the initial data, because of the way the trial was designed, there was some data sparsity, there were some gaps in our data that we hope to fill using national data. Our methods massively supported, it's slightly covered there at the bottom, but by Public Health Scotland teams in SMI and eDRIS. There was linkage between the Scottish medical imaging, so the CT scans, and also Scottish stroke care audit data, which is the routine data collection that occurs for every patient in Scotland who has a stroke. We got data from across Scotland for an entire year to deal with, and we used those linkages to identify ischemic strokes at a known onset time, because we needed that for this purpose, and we excluded a particular type of stroke that isn't likely to have a measurable lesion. We then calculated the elapsed time from stroke onset to CT in all of these patients, and then filled those to gaps that we had in our existing CT clock data. We also sub-selected a predefined validation cohort. So this was 100 consecutive patients from across Scotland that were not involved in this development that we would later use for testing. And the results are quite straightforward. Effectively, we increased our CT clock data set, nearly double the number of cases that are in there. And now these are real cases entirely, as opposed to ones from clinical trials. And then we validated it using the same techniques before, trying to work out how effectively we can identify patients who are under 4.5 hours. And you can see that our sensitivity has dropped slightly and our specificity is also static. So the drop in sensitivity defines the fact that we've now got these sicker patients in, because those patients are what we call fast progressors. Even though they're at 2 hours, the brain looks like it's at 6 or 7 hours, and they probably shouldn't be treated actually. And the specificity hasn't changed because those patients who are prolonging their time, making themselves look like they're under 4.5 hours, well, they're still there. So in summary then, in conclusion, stroke is a devastating disease, common cause of death and disability in Scotland. but not all patients are eligible for effective emergency treatment, particularly if you don't live in a major city in Scotland. But our CT clot methods could allow a greater number of these patients from across Scotland and from other parts of the world who are similarly burdened to be offered treatment. And we're using this validation from SMI to then go forward with prospective testing, which is the next step before this can become a change in clinical practice, hopefully. And SMI enabled that. So thank you very much for listening and to our funders and collaborators. And now I have to introduce Miguel O Bernabeu, who is a professor of computational medicine at the University of Edinburgh.
Thanks, Max. Apologies that I had to leave the room. I had an NHS appointment, and that's not something that you want to miss. They're difficult to get hold of. Right, so for poetic effect, I've called Scone the eyes of SMI, right? And I think that is pertinent because Scone is a project that we've developed for the past 5 years in very close collaboration with a lot of people involved in SMI. And really their learnings have really allowed us to stand on the shoulder of giants and really be able to deliver what I think is a really truly unique data repository that I think speaks to what it was being said at the beginning of the meeting today of what great data assets we can bring together and enable sort of better outcomes for patients and economic growth, etc. So I'm going to use just as a use case to sort of motivate what I'm talking about. What it is known at the moment about Alzheimer's disease, which is a common cause of dementia, and is that by the time that Alzheimer's disease is diagnosed, it's been potentially several decades of a disease process that has been going along silently. And by the time that those clinical symptoms are manifested and can be diagnosed, there is little that we can do for those patients. Now, we know that if we recruit a cohort of patients with clinically diagnosed Alzheimer's disease, and we look at their retinas, we can study how complex the vascularization pattern in their retinas are. And we find very clear differences between those with a diagnosis of Alzheimer's and controls. And this is not only relevant to vascular branching complexity, there's also reduction in those two layers of the retina. So there is quite a distinct footprint of cognitive decline in the retina. Now, obviously, these are people who are already diagnosed with Alzheimer's, but the question for us is, could we leverage these changes in the fundus of the eye to discover preclinical signatures of Alzheimer's? And this is pertinent because as we learned 2 years ago from the Lancet Commission report on dementia, 45% of the risk is modifiable in midlife. We are seeing increasingly new treatments coming online to slow disease. And this is really a space of action where we want to move into this preclinical phase. And at this point, we can do two things. We can either spend millions of pounds recruiting a large cohort and follow them for the next 10, 15 years, or we can do what Scone is proposing, which is go back to images that were collected over the past 2 decades throughout Scotland in optometry practices and use the potential of data linkage to deliver sort of that kind of research at a much faster pace. So let me tell you a bit more about this, right? So unlike brain MR or brain CT or any other modality of radiology, retinal imaging is readily available in most high streets of major cities and towns. You will find several of these optometry practices which have the kind of equipment that is necessary to inquire the changes that I've explained to you a second ago. And furthermore, there is increasingly advancing technology where we are starting to even see consumer grade fundoscopy technology. So this is really moving at a very fast pace technologically. So what we set out to do in school was to collect 10 million NHS-funded retinal images that exist in some 900 practices throughout the country, and very importantly, leverage the SMI and eDRIS infrastructure to link them to other health records that have been discussed today, so that we can deliver AI technology for eye and brain disease prediction. So this project has been going on for 5 years. There was an initial proof of concept phase where we had to figure out data governance, IT infrastructure, engage with optometrists. We gathered support from the Scottish government that has repeatedly issued memos to optometry practices, advising and encouraging them to participate in the project. And it was really a phase where a lot of the legal basis and the IT infrastructure had to put together. So we were with 9 optometry practices to run a pilot, and we were able to gather about 100,000 images and bring them into the national Lochhead and seed them, link them to health records. And that was very successful. There was a second phase where we attempted a Scotland-wide rollout. We work with practices in 10 out of 14 NHS boards. We've visited already 43 practices of those. There are 103 in the pipeline, and the resource has now grown to 1.5 million retinal images or thereabouts. And along the way, we've been developing AI technology for, in this case, discovering early signs of age-related macular degeneration, which is a very important disease of the eye. Now, along the way, we received a major investment from a partnership of funders called NURI, where we were able to leverage the data set, leverage the technology for analysis of images to develop a pilot project on brain health lifetime monitoring. And there was a big push on understanding routes to translation in this project. So understand, how we can protect the IP, how can we turn those algorithms into products, what would be potential business models to take this technology forward. And a few months ago, we were awarded one of 30-something UKRI Proof of Concept Awards across the UK, where we really are making a very big push at understanding and designing the clinical pathways that might one day integrate this kind of technology. We form a partnership with Alzheimer's Scotland and their brain health centers. So they're really making a big push towards sort of translation of these results. And I would argue, hopefully I've convinced you by now, that this is the largest primary care retinal image repository in the world. And what makes it really unique is the capacity to link it to brain images, as my colleagues were describing before, hospital records, prescription data, death data, administrative data, as Professor Sudlow mentioned before, etc. So some very quick statistics on the first 300,000 images. That is the number of images per year of collection, per year of acquisition, sorry. So those going back a couple of decades, is the bulk of the images. That is the distribution by biological sex of representation of female, as is not unusual in screening programs like the ones that these images are collected for. What you have there in light blue is the distribution of socioeconomic status of the deprivation index in Scotland, and what you have in purple is the SCOON database. So we have an overrepresentation of those less well-off in society, which is quite critical because often these segments of society are underrepresented in research. And here, what I have is a table which is very crowded, but hopefully tells you for your disease of interest, be it an eye disease, which obviously has a footprint in the eye, obviously, or for a neurodegenerative disease, or for a cardiometabolic disease, what are the number of patients that we've been able to identify within a SCOON, what is the number of images that we've collected, and how many images predate the first code for Alzheimer's, glaucoma, stroke, and how many images postdate that first code. And it is really critical, this part of having large collections of images that predate the first code, which is the gap that I identified on my first slide. So now here what we have are hundreds and thousands of images that describe trajectories of people in the preclinical state of the disease. And this is where really the potential for early detection and risk characterization really lies. And what are we doing with this? This has been discussed already. We are creating AI technology for eye and brain health monitoring, thanks to the National Safe Haven, where we can ingest the images. They can be linked on demand to nationwide health records. We are developing supervised machine learning approaches to predict clinical outcomes from images. But we are also interested in building the evidence that supports why these retinal biomarkers are predictive of brain health. And we do this by linking retinal images to brain scans, to feature engineering, like the kind of work that Grant and colleagues do on brain scans, and really look at those associations between changes in vascularization and, for instance, neuroimaging markers of a small vessel disease, of stroke, etc. And it's been said already today, Scotland is arguably one of the best places in the world where this research can be carried out at scale, for now at least. And it's incredibly important that we mobilize the resources to keep ahead of the curve here. So obviously, I'm just one of very many colleagues that are involved in this project, including my colleague, Dr. Claire Tockel, at the end of the room. And I have to acknowledge a large number of funders that have believed in this idea. And with this, I'll hand over to, I don't know, it's me.
Thank you.
Thank you.
Thanks again. Hi everyone, I'm Layla Robinson. I'm COO of RDS, and my job here is pretty simple. I've got a couple of brief comments, and then I'm going to facilitate questions in the chat. So if you haven't already, please do put questions in. But as Elizabeth had said, much more eloquently than me, a lot of the benefits of SMI and what has been developed by the SMI team and others involves the work of many people, but quite a few of them are in the room. And that involves academia, government, NHS, as well as the private sector working together. And we've touched on what SMI is and some of the things that it could be, and some of the great work that has been done by people in the room around cardiovascular disease, stroke, and also brain health. So as I say, really, I'm just going to keep it simple. People have fantastically kept to time. So we've got a good 20 minutes, should you want it, for questions. So I'm just going to work through the ones in the chat that we've got so far. I think the first one is for the SMI team. And is there a data catalogue or any plans for a data catalogue? And it's from William Cawthorne, who applied for an MRC grant last year. And there were some challenges around estimating breakdown of participants, and that searchable data catalogue would be really useful. Thoughts?
So I'd say for starters, we've probably got the basics of a data catalogue within the HDR UK gateway, where you find all the information, kind of metadata around the data set. I'm presuming you're talking about a bit more of an in-depth sort of medical imaging specific data catalogue.
Searchable.
Yeah, searchable. Yeah, so at the moment we don't have that, but we kind of have a wish list of things that we want to do for the future, and that is one of the things that is on the wish list to do at some point in the future. So it's good to hear and get those questions, because that just kind of emphasises the need for it. So thank you for that.
Thanks, Carole. And then there's a question from Ed Mountjoy. And how does SMI approach the governance of exporting trained model artifacts, such as weights from the TRE? I'm looking to Jan over there. From the TRE for downstream use in regulated clinical products, such as AI software as a medical device.
As a medical device.
Yeah.
But I was going to hand that to Jackie because she's working on things.
Yeah, I was going to say Jackie's been working on that.
Well, if I do the first bit, you can.
Okay, yeah, you go for the first bit.
So we work with experts in the field of primacy to make sure that we have enough knowledge to run tests and attacks on models to make sure that the weights are safe to egress. But we also start at the very beginning at the inquiry stage to help researchers design their studies with a view to egressability of models. So for instance, there are some types of models that we wouldn't allow unless the variables that we're bringing into them were sufficiently transformed. So an example would be a support vector machine, unless you are inputting things like measurements across different areas of the brain. Yeah.
Once you've decided that something can be ingressed, say, we can package it up, and it's very much a normal rule, but we can package up the code created and have a technical bit to look at that code, whether it's actual just a standard networks file output that captures the weights. We also have a research project ongoing where we're looking at once your model is trained, basically testing it to see if it exposed any data, and depending on whether that test fails or succeeds, to make that basically a mechanical way of getting those analysis. And then last, it very much depends on the data that we've been training on. So Will prefers pixels, and I'm not so scared about pixels and pixels in the wild. But of course, if you're working on the actual nodes, the free text, for example, then checks to be placed because models that have trained about it.
Thank you both. A very good answer on the spot. There's a question from Sophie Larson around public and patient involvement and mechanisms in place with the community, particularly those who contributed to the SMI data set. So RDS works with the PHS team and eDRIS and SMI on public engagement generally. There's obviously project-based public engagement. I don't know if anybody else wants to add to any of that.
It's very, very important. Within each of the projects that we're describing today, there's huge amounts of patient and public engagement and activity and work going on. The BHF Data Science Centre has a fantastic team of public contributors, and we work extensively with them. And it's great to get their suggestions for what we can do to improve our communication about this, improve our research about this, and what they think as well. So, as well as the work that's been done by Public Health Scotland, it's also the work being done by each of the project teams as well. It's essential.
Completely, really, really important. And we co-host, RDF co-hosts a panel with the Scottish Centre with the data research to support particular topics. But there's more, obviously, that could be done with this. And we're really keen to make sure it's all underpinned by proper public engagement. A comment from Paul Colville-Nash that it's an outstanding resource, which is good to hear. That's why we're here today. Have you had an opportunity to share your learnings with the developing HDRS service in England? I don't know if this is a question, but it's a nice comment. Yeah. You may have done much of the heavy lifting to expand these opportunities across the UK. I don't know if Carole or Cathie wants to add to that.
Yeah, so we've been engaging quite collectively as a Safe Haven network in Scotland with the Health Data Research Service team, and essentially kind of demonstrating what capabilities we've got within Scotland, what we can do with that, and with further investment and work, we can bring these things like medical imaging to the table on a UK wide and look, I think, as part of the Health Data Research Service, is kind of looking at where the strengths are across the UK, and that the service taking advantage of those, and not necessarily trying to duplicate effort across, but recognising those centres of excellence. And I think this is definitely one of those ones that we've certainly been demonstrating in our conversations with HDRS so far.
I would maybe just add that, so HDRS has only quite recently appointed its leadership. So Mel Iveson, the CEO, started actually very quickly after her role was announced, which is brilliant. So she's been in place for just over a month now. And building for a while, it was just her and the chair of the new GovCo, Nicola Backwood. So she is already engaging very broadly, and I think really helpfully, and it's really good to see she's making some early visits to the devolved administration. So I believe she's coming up here in April. Yeah. And I think the role of those around the table, particularly Carole and her team and Roger and team, will be to showcase some of the initiatives that are being led from Scotland that are genuinely trailblazing, and the SMI is one of them. There are a few others which I would argue are things one would want to kind of push prominently to the forefront and say these are things we are doing that are not being done anywhere else in the UK, and indeed in some circumstances nowhere else in the world, that are real opportunities for investment. I think that'd be a really strong way of interacting. I mean, there are other things that are happening in Scotland which are, quite frankly, not particularly better than other parts of the UK where we want to. And the reason those are important is because that linkage point. So if those aren't up to scratch, the other really special things can't benefit. Hence primary care linkage being, for example, particularly.
And as you say, I mean, we are working with the Safe Havens National and the regionals and others to highlight what is working well and where we could make it more sustainable by working within the HDRS and the investment that they've got.
Yeah,
that's a really good point. There's a question from Alan Pinder about the time frame for updating the SMI DICOM data store from 2018 to present day. Is there anything we can say on that?
So at the moment, the National PAC system is migrating to a new provider. So we are engaging with National Services Scotland colleagues around where the opportunities might lie in being able to update our imaging data, because we are aware that obviously time is moving on, and we only have images up to 2018. So if we can get more up-to-date images in, then that kind of lends itself to that increasing wealth of that data that's in there. Yes, we are engaging with our colleagues there.
There's also a suggestion or follow-up point around the medical images available in the regional safe havens, particularly the mentions data lock, and obviously if there's anything you want to say there about linking up or the work that's done generally across the network.
Maybe mention something about data log being a regional data set with very deeply phenotyped data. We've previously taken the information from there and brought it to the Scottish Medical Imaging data set, and we're actually able to combine and work across the different data sets, because every data set has different things. So there is a potential to bring information of more deeply phenotyped nature from these other data sets.
Thank you. It's really helpful. So we've only got one or two more questions, so it's nice to be able to make our way through them if anybody has any final ones. Can the SMI team comment on your cost model for researchers and private sector?
Yep, so our cost model, we've been very lucky up until a couple of years ago, where we've had large scale research grants that have funded the infrastructure behind a lot of this stuff. Unfortunately, that we don't have that kind of what we call kind of core infrastructure funding now. So we've been working on a new costing model. It's been introduced at the start of this financial year, because we have to recoup our costs in order to run and maintain the infrastructure and provision the services to support the research community. So we've kind of building on our knowledge base from over the last few years, kind of developed a costing model in respect of that, and we'll kind of keep constantly reviewing that. But it's a challenging space, and we do appreciate that these are costs that not everybody wants to cover. And if we had some core infrastructure funding kind of layer, that would certainly help us a lot, both in respect of being able to maintain the infrastructure and reducing cost to customers, but also potentially allowing us to do some of the development so that we can continue to enhance and develop the infrastructure to be able to support the research community, which in itself then will, would create economies of scale and allows, as we keep kind of reviewing and revisiting the costing model, the more that we have in place that reduces the cost, we can then revise and bring our costs down over time. So it is all very much cost recovery. So it is recouping the costs that enable us to run and maintain and provide the services around the infrastructure.
I've got two more questions, perhaps unsurprisingly, around timeframes and costs. One is from Ed Mountjoy. What approximate timeframes can users expect from initial application to first analysis ready data sets? For example, 10 to hundreds of thousands CTs linked to coded EHR data. Is it possible to give us a...
Well, I think that kind of, I'm sure Jackie and Rob will step in, but that really depends on what the project is as well. So that's why it's very important that we engage very early on, and we can have those conversations, and we can kind of, you know, understand your questions, understand your asks, understand your requirements, and work with you to kind of do all that upfront planning that will kind of then speed up the kind of back end, so that we can then plan and we can schedule in, because we're only a very small team on both the EPC side and the eDRIS side around this space, so it allows that kind of all that kind of preparation, planning, communications allows us then to do that kind of scheduling in. I don't know if Rob and Jackie want to add anything else.
So projects like the ones that Will and Michelle have talked about, where we've got linked databases already set up and established, they have faster permissions processes. And certainly just now with the brain MRIs and CTs that are linked, we use S3 to be able to access all the images quickly. That saves us disk space as well, but it does mean the data provisioning is far faster.
Yes, I think with the correct preparation, we have to turn around sort of 2 to 3 months from initial inquiry to data delivery.
Last question, and then you're off the hot seat, I think. And it's mainly for the SMI team, but there is an element of brain health in here as well. Thank you for this fantastic work and all the presentations. They're interested in using multimodal brain imaging data to train a foundation model. The questions are, as I understand, the data can be only used within your platform. Are there restrictions on what kind of AI models can be used in the platform, and in terms of exporting those models, and then application costs and timelines?
I mean, I think the restrictions would be more to do with what can be egress than what can be run. This is a technical reason regarding what type of model can be run in there, but the restrictions become when you take the model out. The more data that the model contains, the harder that is for it to be safely egressed and be released to the wild. In terms of the technical infrastructure.
Yeah, we have dedicated compute accelerators, GPUs for NVIDIA CPU next to the Halliday, and also a compute or CPU set over 500 CPUs there. So in a sense, we can scale up quite easily. Generally, it's about memory and outside the size of the model can be a restriction, but we can help. We've got staff that have expertise with analyzing these models, so run quite large.
I think that's it. I think all I'm left to say is just a big thank you to everyone who joined online and stayed with us, and to all of the speakers in the room, and being so gracious and moving around and sticking to time. That's always appreciated. A particular thank you to Professor Whiteley, who suggested this in the first place. I think it's been really, really useful. Really keen to hear from anybody. We'll send the slides around and a bit more information. Ollie's puts a link in the chat if you've got an inquiry. And then, yeah, please do come back and talk to us if you're interested in supporting the service. Thank you.